Hello everyone. In this video we will be studying about biomechanics of thorax. Thorax is also known as ribcage. It is made up of thoracic vertebrae, ribs and sternum. Anterior border of thorax is formed by sternum. Lateral border is formed by the ribs. Posterior border is formed by thoracic vertebrae. Superior border is formed by jugular notch of sternum. Superior border of first costal cartilage, first rib and first thoracic vertebrae. Inferior border is formed by xiphoid process. 6th to 10th costal cartilage, inferior portion of 11th and 12th ribs and 12th thoracic vertebrae. Important function of thorax: provide the base for the muscle attachment of upper extremity, head and neck, vertebral column and pelvis. Provide protection for heart, lungs and viscera. Role in ventilation: this process of ventilation depends upon mobility of rib and ability of muscle to move thorax. General structure and function of ribcage: first one is sternum. It is osseous protective plate of heart, composed of manubrium body and xiphoid process. The manubrium and the body of sternum form a dorsally concave angle of approximately 160 degrees called angle of Lewis. Xiphoid process and the body of the sternum forms angle dorsally, but it is difficult to palpate. Second one is thoracic vertebrae. There are total 12 thoracic vertebrae which makes the posterior aspect of ribcage. Third one is ribs. There are total 12 pairs of ribs. Gradually increase in length from 1 to 7th and decrease again from 8th to 12th. 3 to 9 ribs are typical. 1 to 10, 11 and 12 are atypical. 1 to 7 ribs are called as true ribs. 8, 9 and 10 ribs are called as false ribs. 11th and 12th are called as floating ribs. Joints of the ribcage: manubriosternal joint, formed between manubrium and the body of the sternum, also known as sternal angle or angle of Lewis. Type synchondrosis. Fibrocartilages is between hyaline cartilage. It covers articulating end of the manubrium and the sternum. Xiphisternal joint, formed between xiphoid process and the inferior aspect of the sternal body. Type synchondrosis. Costovertebral joint, formed by head of the ribs and the two adjacent vertebral body. Type synovial joint. Superior facet articulate with inferior facet of vertebrae and inferior facet articulate with superior vertebrae. 1, 10, 11th and 12th atypical ribs articulate with only vertebral body. Typical ribs articulate with its own vertebrae and also body of next higher vertebrae to form two plain synovial joint separated by intra-articular ligament. Costotransverse joint, tubercle of typical rib articulates with transverse process of corresponding vertebrae. Type synovial joint. T1 to T6 have slightly concave costal facet on transverse process and slightly convex costal tubercle. This allows slight rotational movement. T7 to T10 both the articular surfaces are flat, so in this gliding movement occur. Costochondral joint, anterolaterally articulation of first to 10th rib with costal cartilage. Type synchondrosis. This joint permit no movement. Chondrosternal joint, articulation of costal cartilages on the rib 1 to 7 anteriorly with sternum. Rib 1 attached to the lateral facet of manubrium. Rib 2 attached to second demifacet of manubriosternal joint. Rib 3 to 7 attached with lateral facet of sternal body. Type first, 6th, 7th are synchondrosis, 2nd to 5 are synovial. Interchondral joint, costal cartilage of 7th to 10th articulate with costal cartilage immediately above them. Type synovial joint, supported by capsule and interchondral ligament. Ligament that support vertebral joint: anterior longitudinal ligament, posterior longitudinal ligament, ligamentum flavum, intraspinous ligament, supraspinous ligament, intertransverse ligament. Kinematics of rib and manubrium: each rib may be regarded as a lever. The fulcrum lies lateral to the tubercle. Because of the disproportionate length of the two arms of the lever, the slight movement at vertebral end of the rib are greatly magnified at the anterior end. The anterior end of the rib is lower than the posterior end. Therefore, during elevation of the rib, the anterior end also moves forward. The antero-posterior diameter of the thorax is increased. Along with up and down movement of 2 to 6th ribs, the body of sternum also moves up and down. Is called as pump handle movement. The middle of the shaft of the rib lies at a lower level than the plane passing through the two ends. Therefore, during elevation of the rib, the shaft also moves outward. This causes increase in transverse diameter of thorax. This movement is termed as bucket handle movement. Zone of apposition: portion of the diaphragm is closer to the lower ribs. When diaphragm descends, there is increase in intra-abdominal pressure, which transmits pressure back to the flattened diaphragm. Pressure is transmitted to the lower ribcage to expand more. Altered mechanism of respiration in COPD. Paradoxical breathing. A major clear chronic obstructive pulmonary disease is a hyperinflation of lungs due to destruction of alveolar walls. The resting position of thorax depends on the balance between elastic recoil properties of the lung pulling inward and the outward pull of the ribcage. As tissue destruction occurs with disease, the elastic recoil property of lungs is lessened. More air is now within the lungs at the end of the expiration. Hyperinflation of lungs. A more barrel-shaped chest is seen at rest. Increase in anteroposterior diameter of chest. Hyperinflation affects not only the bony component of the chest wall but also the muscles of the thorax. The resting position of diaphragm changes to a more flattened. The angle of the diaphragm fibers become more horizontal with a decreased zone of apposition and decreased strength and range of contraction. In hyperinflation, there is shortening of sternocleidomastoid muscle, making them much less efficient. Also, the diaphragm has very little available range of motion. The majority of inspiration is now performed by accessory muscles, particularly the parasternal and the scalene. The upper ribcage is pulled upward and outward. The diaphragm has limited ability to push the abdominal content down. In this paradoxical thoraco-abdominal breathing pattern, the abdomen is pulled inward during inspiration and it is pushed outward during expiration. The disadvantage of this biomechanical alteration in hyperinflation are compounded by the increased demand of ventilation in COPD. More work is required for less effective system. The energy cost of ventilation or the work of breathing in COPD is increased. Muscles of inspiration. In quiet inspiration, diaphragm and external intercostal muscle. In deep inspiration, diaphragm, external intercostal muscle, sternocleidomastoid muscle, scalene, levator costrum, serratus anterior. Forced inspiration, diaphragm, external intercostal muscle, sternocleidomastoid muscle, scalene, levator costrum, serratus anterior, levator scapulae, upper trapezius, rhomboid, pectoralis major. Muscles of expiration. For quiet expiration, muscles are relaxation of external intercostal muscles, elastic recoil of wall of lungs. Forced expiration, muscles are internal intercostal, rectus abdominis, external oblique, internal oblique, quadratus lumborum, transverse abdominis, serratus anterior. Lung capacity and volume. Tidal volume. It is the volume of air breathed in and out of the lungs in a single normal quiet respiration. Normal value is 500 ml or 0.5 liter. Inspiratory reserved volume. It is additional volume of air that can be inspired forcefully after the end of normal inspiration. Normal value is 3300 ml or 3.3 liter. Expiratory reserved volume. It is additional volume of air that can be expired forcefully after the end of normal expiration. Normal value is 1000 ml or 1 liter. Residual volume. It is volume of air remaining in lungs after forced expiration. Normal value is 1200 ml or 1.2 liter. Inspiratory capacity. It is maximum volume of air that can be inspired after normal expiration. Inspiratory capacity is equals to tidal volume plus inspiratory reserved volume. Tidal volume is 500 and inspiratory reserved volume is 3300. So 500 plus 3300 is equals to 3800 ml. Vital capacity. It is maximum volume of air that can be expelled out forcefully after deep inspiration. Vital capacity is equals to inspiratory reserved volume plus tidal volume plus expiratory reserved volume. Inspiratory reserved volume is 3300, tidal volume is 500, expiratory reserved volume is 1000. So 3300 plus 500 plus 1000 is equals to 4800. Functional residual capacity. It is volume of air remaining in lungs after normal expiration. Functional residual capacity is equals to expiratory reserved volume plus residual volume. Expiratory reserved volume is 1000, residual volume is 1200. So 1000 plus 1200 is equals to 2200 ml. Total lung capacity. It is volume of air present in lungs after deep inspiration. Inspiratory reserved volume plus tidal volume plus expiratory reserved volume plus residual volume is equals to total lung capacity. So the total is 6000 ml.